Okay, so welcome back to this next video in which we are discussing the drug treatment of rheumatoid arthritis. Okay, so we're in the process of discussing the pathogenesis of rheumatoid arthritis. So we've discussed that the turning point where you go from the pre-articular phase to the articular phase, which is called this transition phase, is when you start producing antibodies that are directed against citrullonated fibrinogen. And this results in you having circulating immune complexes within the blood. And these circulating immune complexes within the blood are capable of producing acute inflammatory responses in the distal extremity joints. Now, this is not well understood, but what may happen is this, okay? It seems specific to the distal extremity joints as well, such as the finger joints and the joints between the toes. Okay, basically what may happen is you may start off with these circulating immune complexes. Okay, circulating immune complexes. And maybe they are capable of initiating the acute inflammatory response on their own, but alternatively, maybe maybe what follows is that you get a microbial insult or a mechanical insult to the joint. Okay, so potentially you get a small infection, potentially, or you may well just get a mechanical injury to the joint. Okay, so you may get a little mechanical insult, some little mechanical damage to the joint. Okay, now what this will lead to is a tiny little increase in the vascular permeability. So vasopermeability may go up a little bit, and this may well allow immune complexes to leave the blood and go into the interstitial fluid. So vasopermeability will go up a little bit, and these immune complexes may well be then able to leave the blood and go into the interstitial fluid, and here they're going to activate the sentinel cells that are present within the interstitial fluid. This is one model, basically. However, there are many different speculations. What seems to happen, however, is that these immune complexes are going to activate sentinel cells in the synovium. The reason for this is not clear, basically, because the sentinel cells are not lining the blood vessels, so they're not seeing the blood, so somehow the immune complexes need to get out of the bloodstream. And one way that this may happen is that you may get microbial insult or mechanical insult, which leads to an increase in vasopermeability, which allows these circulating immune complexes to leave the blood, go into the interstitial fluid, and then what they're going to do is activate receptors on the surface of the sentinel cells that are present within the synovium. Now, which sentinel cells did we see present in the interstitial fluid of the synovium? Well, we saw 3. Okay, so let's talk about them now. So, we'll start off with the dendritic cell over here. So remember, this cell had dendritic processes coming off its cell body, and these make it look like a neuron. However, it has absolutely nothing to do with a neuron. It is not capable of conducting action potentials. It will have an electrical potential difference across its membrane, all cells have that, but it won't have the voltage-gated ion channels that are necessary in order to conduct an action potential. Okay, so this is called a dendritic cell. Okay, and they're often abbreviated to DCs for short. Right. Then we also saw that we had resident macrophages in the subintima. Okay, now we also had those macrophages that were type A synoviocytes, but their role really is more in making sure that the synovial fluid doesn't have any nasties in, removing those. So the macrophages that are within the subintima, however, are most definitely there for immune surveillance. Okay, so here is our nucleus of our resident macrophage. Okay, and this again is a sentinel cell. So when it sees signs of pathogens, it's going to send out alarm signals which are going to initiate the acute inflammatory response. Okay, so resident macrophages, and then finally the final cell type that we saw present in the intima was mast cells. Okay, so here is the nucleus of the mast cell. And now I can draw the mast cell granules in a bit more detail. So remember, mast cells had these vesicles called granules, which were full of histamine, okay, which I'll show as these turquoise dots. Okay, and when they become alerted to the presence of a pathogen, they will degranulate, which means they'll release their histamine granules, and they'll release the histamine into the extracellular fluid. Okay, right, so how are the immune complexes that have come in to the interstitial fluid from the blood, these immune complexes of citrullonated fibrinogen bound to the anti-citrullonated fibrinogen antibody, how are those going to activate a receptor? Sorry, how are those going to activate these sentinel cells? And I should just put that piece of terminology somewhere. So sentinel cells, these are cells that are on guard, basically. They're always looking out for signs of pathogens. Okay, well basically, all of these sentinel cells have on their surface receptors that can bind to IgG antibodies. Okay, so I'll draw these here. Okay, so remember I said that the main form of antibody that you produce, the main form of immunoglobulin that you produce, which is just, remember, another name for antibody, is IgG, immunoglobulin of the G type. So on the surface of all of these sentinel cells, you have receptors which are called Fc, which means fragment crystallizable, gamma, and then R. So basically this tells you that they bind to the Fc region of immunoglobulin G molecules, and they're a receptor basically. So they're a receptor for the Fc region of IgG molecules. So basically, if you have an IgG molecule, it can come and bind to this receptor here. Now there are loads of different types of Fc gamma Rs. To keep this simple, we'll just call them, generic Fc gamma Rs. Okay, now, basically, when the citrullinated fibrinogen, anti-citrullinated fibrinogen immune complexes come into the interstitial fluid, they will bind to these Fc gamma Rs on the surface of the sentinel cells, because generally the antibody that's involved in the immune complex will be an IgG antibody, and that will activate the sentinel cells basically. Now you might ask, well, why? Why do these sentinel cells have this Fc gamma R on the surface of their phospholipid bilayers, and why does it activate the sentinel cell? Well, you have to remember, what is the purpose of creating antibody against something? You usually create antibody against proteins that are highly dangerous, or proteins that are associated with a pathogen. So basically, usually, when you have an immune complex like this, when an antibody is bound to an antigen, it indicates the presence of an antigen. It indicates the presence of some highly dangerous pathogen. So basically, that is why immune complexes should activate these sentinel cells. Basically, it's a way for the sentinel cells to be primed against this specific protein here, whereas they didn't have that mechanism innately, basically. So it's a way of upgrading your sentinel cells, basically, because now they can respond to these these new proteins, basically. You can produce an antibody against some protein, and by producing that antibody against the protein, the sentinel cells can use the antibody to sense the presence of that protein if it ever should arrive again. So basically, these sentinel cells think that they have been alerted to the presence of some highly dangerous pathogen because the immune complex is bound to them. Okay, and I should emphasize that if the antibody alone binds without the antigen, that would not activate the Fc gamma R. It has to be an immune complex. It's once it's got its antigen bound that it then activates the Fc gamma R. Okay, and this is going to lead to the activation of these sentinel cells, so they think they have detected some horrendously dangerous pathogen. In reality, they've just detected a tiny bit of citrullonated fibrinogen. Okay, and what's going to happen is these dendritic cells and resident macrophages are going to start secreting interleukin-1, okay, and tumor necrosis factor alpha, and these are so important that I should probably write out their names in full at least once. So IL-1 is short for interleukin 1, okay, and TNF alpha is short for tumor necrosis factor alpha. Okay, so interleukin 1 and tumor necrosis factor alpha are both proteins that the dendritic cells and resident macrophages are going to start producing in response to immune complexes coming into the interstitial fluid and activating their Fc gamma Rs. Okay, and the mast cells are also going to start sending out alarm signals. They're going to start sending out histamine, so they're going to degranulate and release histamine. Now, note the time difference. The mast cells only have to exocytose vesicles that are already full of histamine. The dendritic cells and resident macrophages are going to actually have to synthesize interleukin 1 and tumor necrosis factor alpha from scratch. They're proteins, so that's going to take time. So it's going to take much longer for the dendritic cells and resident macrophages to produce interleukin 1 and tumor necrosis factor alpha than it is for the mast cells to produce, well, to release histamine. Okay, so this will happen in seconds, basically. This will take potentially hours to make the protein. Well, maybe not hours, but, you know, considerable time compared to how quick the mast cells will exocytose their histamine. Okay, right. I should also emphasize that it isn't completely understood whether this step of the microbial insult or mechanical insult is necessary. It seems logical that it would be necessary, but potentially the circulating immune complexes themselves are capable of initiating the acute inflammatory response without any mechanical insult or microbial insult. Okay, so maybe the circulating immune complexes can activate the acute inflammatory response in the blood vessels within the synovium of distal extremity joints without actually leaving the blood vessels. But we don't know, basically. Something happens and you launch an acute inflammatory response. So, what's now going to happen is these sentinel cells releasing these chemicals, these pro-inflammatory mediators, is going to cause the acute inflammatory response. So, histamine is going to diffuse from the mast cells to the capillaries, the arterioles, and the venules. Okay, so remember our picture here. So it's going to diffuse from this mast cell to the capillaries, to the post-capillary venules, and also to the terminal arterioles. Okay, and it's going to act on the endothelial cells of these three types of blood vessels, and it's going to cause what is known as type 1 activation of endothelial cells. Okay, and type 1 activation occurs within minutes. Once histamine is bound to its receptor on the surface of the endothelial cell, type 1 activation will have occurred within minutes. Okay, interleukin 1 and tumor necrosis factor alpha, these both have receptors on the surface of the endothelial cell, and they'll bind to them, and they'll trigger what is known as type 2 activation of the endothelial cells. Okay, now both of these trigger pretty much the same thing. Type 2 activation really is just an improved version of type 1 activation. Okay, so type 2 activation does take longer, however. It takes hours to occur, whereas type 1 activation takes minutes, basically. And the reason is that type 2 activation is going to involve a total change in the expression of proteins in the endothelial cells, whereas type 1 activation doesn't involve any new proteins being synthesized. All of the proteins involved in type 1 activation will already be present. Okay, so overall, what's going to happen in both type 1 activation and type 2 activation is they're going to lead to the acute inflammatory response, okay? And we will look at these more later on when we're discussing drugs that are going to block this acute inflammatory response, okay? So, acute inflammatory response. Now, what happens in the acute inflammatory response? Well, there are three main components of the acute inflammatory response. Firstly, the terminal arterioles are going to vasodilatate. Okay, so let me discuss this first. So, the smooth muscle cells that line the endothelial cells of the terminal arteriole, those are going to relax, and when they relax, then the circumference of the ring of smooth muscle cells will increase in length, basically. And this will lead to the diameter of that ring of smooth muscle cells increasing as well. So when you increase the diameter, you increase the when you increase the circumference, you also increase the diameter, and that will lead to the diameter of the lumen of the terminal arteriole increasing, which is called vasodilatation. Okay, so when you increase the diameter of the lumen of a blood vessel, it's called vasodilatation. Now, what's the significance of vasodilatation of the terminal arterioles? Well, basically, it's going to increase the blood that can flow through the terminal arterioles and therefore increase the blood supply to the synovium. Okay, so blood flow through the synovium is going to go up. Okay, now, remember what the body thinks it is doing. It thinks that it is initiating a response to the presence of an extremely dangerous pathogen. These pro-inflammatory mediators, histamine, interleukin-1 and tumor necrosis factor alpha, they are cries for help, basically, from these sentinel cells. They are alarm signals. And basically, they are pleading for the body to send troops that are going to help destroy the pathogen that has come in and is invading, or at least they believe is invading. Okay, now where are all the troops that can fight pathogens? Well, they're all present within the blood. So, you have to move these troops from the blood into the interstitial fluid of the synovium. Now, if you vasodilatate, you get an increased blood flow through the synovium. So that means more troops per minute are flowing through the synovium. So the number of troops that potentially you could move from that blood that's flowing through the synovium into the interstitial fluid of the synovium is therefore increased. Okay, so that's the purpose of vasodilating. It's going to allow us to recruit more troops from the bloodstream into the interstitial fluid. Okay, now we need to look at the other components, which are the components which actually are going to move the troops from the blood into the interstitial fluid. So firstly, you're going to get an increase in vascular permeability. So vasopermeability is going to go up. So the endothelial cells which line the blood vessels are going to retract their outer extremities, if you like. They're going to move, they're going to retract their edges. Okay, so if I draw a little picture of this. So let's say this is an endothelial cell here. Okay, and here is its neighbouring endothelial cell here. Usually there are very tight junctions between neighbouring endothelial cells, okay, which mean that there's not a gap between the two. However, once you've initiated the acute inflammatory response, what will happen is you will basically retract these edges, okay? So what happens is that if in type 1 activation of endothelial cells, initially the endothelial cell just contracts like a smooth muscle cell, basically. It has contractile units in it which can contract, and it will contract backwards, and that will open up the gaps. In type 2 activation, you make a more permanent change, where you completely dismantle the edges of the cells, you dismantle the cytoskeleton, so that the cell no longer exists here, basically. You change the shape of the cell. Okay, but both of these things will lead to holes forming between the endothelial cells, and this is going to allow fluid to move from the blood into the interstitial fluid, and this fluid that you're going to move is what's known as an inflammatory exudate. Okay, so the fluid that comes out of the blood that wouldn't usually come out of the blood is known as an inflammatory exudate. Okay, right. This inflammatory exudate is going to firstly cause the swelling of the synovium, and also it's not just going to remain in the synovium, it's going to spill into the synovial fluid, okay, and it's going to cause swelling of the synovial fluid. So you're going to get swelling of the joint, basically. You're going to get swelling of the synovium and swelling of the synovial fluid, which will lead to swelling of the joint. Okay. In addition, it contains all sorts of proteins from the blood, which we'll discuss in a moment, but it contains complement proteins, it contains coagulation factors, it contains the components of the kallikrein-kinin system, it contains, importantly, more immune complexes, more citrulliнаted fibrinogen and anti-citrulliнаted fibrinogen antibody, and potentially most importantly of all, remember, there was this citrulliнаted protein 4, as we called it, that was present within the synovium, and I want to stress that it's not really called citrulliнаted protein 4. We don't know what this protein is. I'm just calling it that so that I've got something to call it, basically. Okay. We've got this citrulliнаted protein 4 present in the synovium, and remember, long ago, we created an antibody against citrulliнаted protein 4, which wasn't dangerous because it couldn't gain access to it, but now it's going to flow into the interstitial fluid and also the synovial fluid of this synovial joint, and it's going to find its antigen, and we'll discuss the significance of that in a moment. Okay, right. So you've got vasopermeability, which is going to lead to swelling. You are also going to get the recruitment of leukocytes. So you're going to get leukocyte recruitment is the other key component of the acute inflammatory response. So the movement of white blood cells out of the bloodstream and into the interstitial fluid. Okay, so leukocyte. A leukocyte is just the fancy name for a white blood cell. Okay, so which leukocytes are you going to start recruiting? Well, basically, type 1 activated endothelial cells start recruiting neutrophils. Okay, and that's pretty much all they can recruit. Type 2 activated endothelial cells will recruit a much broader spectrum of leukocytes, but one of the major ones they recruit is monocytes. Now, monocytes, as soon as you move them out of the bloodstream, they differentiate into other cells, okay? And they differentiate, one of the things they can differentiate into is macrophages. Other things that they can differentiate into is dendritic cells, and there are even more things that they can differentiate into, and we'll look at those later. But for now, we'll just acknowledge macrophages. So, you're bringing in neutrophils, you're bringing in macrophages into the interstitial fluid of the synovium. They're also going to overflow into the synovial fluid, and they too will contribute to the swelling. They'll release more cytokines and things that are going to amplify the acute inflammatory response. Okay, so when you get this swelling occurring within the synovial joint, in fact, when you get the acute inflammatory response occurring in the synovial joint, it's known as synovitis, okay? So anything ending in itis means inflammation, okay? So this is synovitis because you've got inflammation of the synovium. Okay, right. So now let's discuss how this is going to perpetuate, basically, because at the moment, yes, okay, it's happened, but surely it should resolve. It shouldn't just go on and on and on, but the reality is that in rheumatoid arthritis, it is now never going to end, basically. It's going to continue going on and on and on and on. Now, why is that? How does it perpetuate itself like that? Okay, well, the reason is that you've now brought these anti-citrulliнаted protein 4 antibodies into the interstitial fluid. You've also brought these citrulliнаted fibrinogen, anti-citrulliнаted fibrinogen antibodies, which form a antibody complex, into the interstitial fluid, and both of these are going to help perpetuate the synovitis that you get in rheumatoid arthritis, and are going to mean that it never goes away, basically. But we'll continue this discussion where we'll discuss this perpetuation in the next video.